So my job is to share with you some of what we know about the three types of vaccination exemptions that Professor Rice introduced: the medical and the religious and personal belief exemptions. And I'm going to do that by talking about a natural policy experiment in California that really generates some very useful evidence. It is one of, I think, the best designed and best studied areas of vaccination policy. And we can really learn a lot about things that have gone right in California and some things that have gone less well than we hoped. By way of
Somehow you got muted again, Dr. Mello.
The vaccination law in California has been unfolding gradually over the last few years. We started out having a personal belief exemption that rolled in a religious exemption. And because of wide use of that exemption, there was an initial attempt with a law called AB 2109 to try to encourage parents not to take up these options by requiring them to undergo counseling with a physician before they did so. That was not very successful, as it turns out, in bringing down rates of exemptions. And so the legislature then moved to a somewhat more coercive approach with a bill called SB 277 passed in 2015. This eliminated the personal belief exemption in California, which included this religious option, essentially bringing us, as Professor Rice noted, into a regime where medical exemptions are the only avenue to opt out of vaccinations. And it provided, notably, that children could continue to utilize an existing personal belief exemption or get one up until 6 months after passage of the law. I'll come back to that later as to why it's important. It also allowed a fairly wide berth for these medical exemptions to be written. It could be written by any licensed physician, basically for any medical reason, and it didn't have to be very specific as to what. Those provisions caused some problems in California, as I'll talk about shortly. And so as a result, we had another piece of legislation passed that just became effective, or will become effective in January of next year, that tightened down the conditions under which medical exemptions can be written out. The physician who requests them actually has to see the child. It needs to either be the child's regular physician, or if that's not the case, the physician needs to explain why it's not the child's regular physician. And there's a process that is set up to allow the Department of Public Health to look for and deal with frequent flyers in the system. Physicians who are writing lots and lots of exemptions for children, there is a process that they could potentially be subject to disciplinary action if those exemptions are found to lack validity or basis. So this is where the law is now. In terms of what we have known about these laws in terms of the impact on vaccination rates, let me just focus on three headlines for what has already become a pretty voluminous body of research, and very well done research, I might add. The first headline is that in the 2 years following the passage of SB 277, that was the 2015 law, the proportion of kindergarten students who were fully up to date on their vaccinations increased from 92.8% to 95.1%. And that's important because that puts us over what scientists agree is the threshold for herd immunity for measles, which has been a major problem in California over the last 5 years. However, second, rates of medical exemptions in California increased after passage of the law. Within 2 years of the passage, they had gone up 250%. By 2019, they had gone up 400%. Now, they're still low. They started out at 0.2% of all children. So this is a big relative increase, but it's not a big increase in absolute terms. But nevertheless, there have been concerns among health officers in California and research that has surveyed them about the validity of some of the exemption requests that they're seeing, and about physicians who are potentially selling these certifications through internet outreach. A small number of medical providers in California account for a large share of the exemptions. Often they're offering this service for a fee and without a prior relationship with the child. And when health officers looked at the exemption, they noticed that they were being written by some providers in fairly odd specialties for this kind of work, like anesthesiology. So there was reason for concern about the validity of those medical exemptions, and that is what led to the subsequent legislation in California. The third headline, based on research by Paul Delamater and colleagues, is that published projections of the overall impact of SB 277 and SB 276 suggests that passage just of the first piece of legislation, eliminating the personal belief exemptions, would have decreased the proportion of kids with any exemption from 2.59% in 2015 to 1.87%, and that adding SB 276, which tightened up that medical exemption requirement, will bring it down to 1.41% by the year 2027. The authors conclude that overall SB 277, our 2015 law, had a modest effect on exemption rates. So this is what we know specifically about California. More broadly, looking at research on vaccination laws in other states, there are 4 things that we now know with a pretty high degree of certainty. The first is that states without non-medical exemptions have lower rates of both vaccination exemptions and vaccine preventable disease outbreaks than states that have those exemptions. Secondly, notwithstanding California's experience with the counseling requirement, in general, the ease with which exemptions can be maintained is correlated with both of those outcome measures. So if you impose, for example, additional paperwork counseling requirements, in general, that is going to have an effect on both the risk of an outbreak and the exemption rate in the state. Third, even though overall impacts of some of these laws, like in California, can be characterized as modest in certain respects, small changes can pack a big public health punch. So based on the Delamater study, for example, when the projected school enrollment for 2027 in California, an estimated decrease in exemptions going from 2.59% just down to 1.41% in California means an additional 84,000 kids will be up to date on their vaccinations. So that's a big effect, and it's especially important because it's not evenly distributed across areas of California. The largest effects tend to be seen in the districts that had the highest exemption rates to begin with. Because a quarter of California's kindergartens prior to the passage of SB 277 did not have vaccination rates high enough to achieve herd immunity for highly infectious disease like measles, that's really important. Just these small increments can pack a big punch in districts that were doing poorly to begin with. Overall, to me, the key lesson from California is that this approach is worth doing, but if you don't do it right, there can really be some problems that have to be patched up down the line. So looking at, again, at the text of the California laws, let me point out a couple of things that have caused problems in California and that I would suggest other states ought to avoid. The first problem here relates to the so-called grandfather clause in SB 277. This law allowed parents to go out and get the very kinds of exemptions that it was eliminating for 6 months after the law's passage, plus about a year leading up to the effective date of the law. So it gave them an opportunity to go out and get exemptions, and those exemptions would hold until the child progressed into what they called the next grade span. So it grandfathered in a lot of kids, and that's going to delay the full effect of the law. Second, that SB 277 bill, again, allowed physicians to write medical exemption for any reason, as opposed to, say, just a valid recognized contraindication to vaccination. And it allowed your neighbor, your brother, your surgeon to write those exemptions rather than insisting that it be somebody who knows the child and is practicing in a relevant specialty. SB 276 fixed some of those problems, but came too late to deal with the grandfather clause problem, and it still doesn't require that the physician seeking a medical exemption be the child's regular pediatrician. It just imposes additional things that the physician has to say to explain why that isn't the case, and it's not entirely clear yet what the Department of Public Health is going to do with that information. So these holes in the legislation no doubt represent political compromises made to get this legislation passed. And of course, that's not unusual. And I have heard legislators in other states say, look, we're just going to adopt this incremental bill. We know it's flawed, but what we're going to do is we're going to show that it works, and then we can go back and patch the holes. I think that's a misguided approach. The notion that those who oppose these laws are going to see that they work and cease their efforts to resist them just doesn't match up with reality. There is going to be continued opposition, and so patching those holes is going to be just as hard as passing the initial legislation. Here in California, there was bitter resistance to the passage of SB 276, culminating in an episode where anti-vax activists threw human blood onto the Senate gallery while they were debating the bill and physically assaulted one of the bill's proponents. So it's important to kind of have a lot of backbone in this area in general, and to, if you're going to do it in a way that's going to really have an effect. So to sum up, I think there's a number of things that California's did right, and some things that we can learn from. It's important to get these details right. It's important to expect opposition from anti-vax groups. And so what does it mean to get it right the first time? I think some of the things that California did right the first time are these: to go after those non-medical exemptions in their full scope and just bring us to a medical exemption regime, to create rules that reach private schools and daycares as well as public schools, to set forth a specific but large list of recommended vaccines, as opposed to, say, Washington State that just focused on MMR vaccine during a measles outbreak and is going to face, this problem again next time it's pertussis where there's an outbreak. And finally, to make data on school-specific exemption rates public, as Professor Rice was talking about, so that parents can put pressure on schools and the health department to continue to be vigilant in enforcing these exemptions. There are also some things we did wrong here in California that I think can be learned from. I think it's important that these laws require that the medical exemption requests come from a physician who is in an appropriate specialty and is in a regular care relationship with the child, to limit the basis for medical exemptions to valid and recognized contraindications, not some vaguely articulated notion of family history, to provide that the Department of Health is going to be able to review medical exemption requests and take action against frequent flyer physicians, those who show up as exemption writers over and over again. I think that incentivizes physicians to be careful and cautious and not give in to parental demands where there's not a medical basis for doing so. It's important to make the Department of Health the lead in enforcing these requirements rather than putting schools in an adversarial position vis-a-vis families. It shouldn't be up to school nurses to resist parental attempts to skirt the law or to submit faulty medical exemption requests. And finally, of course, to avoid the kind of grandfather clauses that we saw in the legislation that delay and minimize its full impact. Thank you very much. I'm very happy to take questions at the appropriate time.